Welcome, everybody. Thank you for taking some time out of your Thursday evening to join yet another Zoom in this post-pandemic life that we call Zoom life. I am so thrilled to be here tonight to be able to bring this information to you. This is a project that has been several years in the making. And so I want to kind of go over and tell you how the night is going to go. So first of all, you're going to hear from Ashley from NAPNAP and how this core competencies kind of came to be. And then you'll hear from Hani, and she'll tell you about Heal Trafficking and what they're doing. And then I'm going to tell you about NAPNAP Partners and the Alliance for Children in Trafficking. We'll be taking your questions about the core competencies, but this is kind of the tool that we've really been waiting for to be able to really help you in your clinical environments to effectively respond to trafficking in clinical situations, that both as an individual clinician, as a healthcare organization, and as an academic institution. So if you are coming here, I see some of your names on here, and I see a lot of anti-trafficking advocate rock stars on here who are probably going to have some hard questions, and I look forward to that. If you're coming in here just kind of new and thinking, I just want to learn about trafficking, I haven't learned anything yet, we will give you some resources. And I just want to make it clear up front that we're not going to talk in detail about trafficking, but we have a lot of resources through SOAR training, NAPNAP provides training, HEAL provides training. You can get training to your heart's content to get more information if you need to backfill some of this information. So if you're feeling lost, just hang on. You can go back and get that and then come into this. If you're from another nursing organization, we welcome you. We're so glad that you're here. We really need to engage nursing organizations, and I'm going to be talking a little bit about that in just a minute. So with that, we're going to talk about, I'm going to give it over to Ashley. These core competencies were really her brainchild, and she's going to tell you how they came to be and our vision for their use. So Ashley, I'm going to give the floor to you.
All right. Hopefully I am going to do right by all of you. It's wonderful to be with you tonight. Again, my name is Ashley Garrett, and I'm the director for NITAC. That's what we call it because it's much too long to otherwise say. Let me make sure I'm going into a slide projection mode. Full caveat that I'm on the East Coast and it's 8 o'clock and it's my 6-year-old's bedtime. So hopefully he and the dog will cooperate, but if not, you might just do a head pop in and so please excuse that. So I am thrilled to share a little bit about the journey that has taken us to this particular publishing of the core competencies for human trafficking response. So I want to start with a little bit of a story. For those of you that are familiar with the Department of Health and Human Services, one of the newest parts of the Administration for Children and Families is the Office on Trafficking in Persons. And that was created under statute to combat human trafficking by supporting and leading systems that prevent trafficking through public awareness and protect victims through identification and assistance. One of the reasons I want to highlight that is, one, they pay for the center that I run. And so, of course, it's really their vision that brought us down this path. But two, it was with this statute and the creation of this office that we really started to see a shift in how human trafficking could be addressed. So historically, for those of you very familiar with the issue and have been working on this, it wasn't until 2000 that we had a statute that recognized what this crime could be. And that was developed as a law enforcement tool. And so what we really saw in the first 10 to 15 years of response in the United States and frankly globally was a focus on a criminal justice response, which is a tremendously important first step, but it is by no means the solution to ending trafficking. And so OTIP was created to really start to push forward a public health and prevention framework. And so in doing so, they created NITAC, which we've been around for 5 years. I will not reread what our mission statement is. Since 2017, we've trained and provided technical assistance to about 125,000 individuals. And a huge part of the work has been focused on how can we build a framework and a standard setting for healthcare and behavioral health professionals. Several years ago, over many cups of coffee and meals and whatnot, including with both Jessica and Hani on the call, we pulled together and created a vision. And the goal of that vision was to really improve outcomes for individuals who have experienced trafficking and individuals who are at risk of trafficking through empowering health and behavioral health systems. The competencies support a transformation of these systems using an effective evidence-based, trauma-informed, and culturally responsive approach to human trafficking. So we want to be visionary and aspirational in creating a system that can support each and every one of you and all of us in moving the needle forward and being able to really fully meet our patients and their families' needs. As I think, as Jessica mentioned, this has been a journey. So we started this journey in 2017. We looked at what evidence base was out there related to core competencies. How do healthcare and behavioral health professionals set standards for themselves? What was the evidence base around human trafficking and the responses and innovations that needed to happen to make sure that we were treating patients and their families correctly and appropriately? And over the next several years, we looked at the literature. We pulled a smaller group of folks together, really leveraging the expertise of both HEAL Trafficking and NAPNAP, but also pulling in folks that represented the International Center for Missing and Exploited Children, the Office on Trafficking in Persons. We looked at creating a writing team that was really reflective of the audience that we wanted to reach, as well as what are the TA and technical assistance resources that are out there that can help move that along. So in the journey, we wrote, we rewrote, we wrote again. And once we got to a place where we felt like we were ready to share something and put it out there, we solicited input and did a series of different peer reviews. So part of that was looking at the target audiences that we were trying to reach, right? Those of you on this call listening, looking at healthcare and behavioral health. But we also wanted to make sure that we were leveraging the expertise of those, particularly with lived experience. So NITAC and these core competencies are indicative of that. Everything that we do is informed by those that have experienced what we are trying to change. We cannot learn or we cannot be effective without bringing the voice of those individuals to the forefront. So I want to do a shout out to all of those. In the actual report is the listing of all of the different professional entities and organizations and individuals that help to inform these competencies. So in the structure, I want to talk a little bit about the structure of it and then turn it over to our amazing partners. But one of the things that became really important is that we wanted to make sure that we were setting up a system that really looked at guiding principles. And in doing that, every system, that every recommendation or competency that we set, we wanted to make sure that we were constantly going back to these guiding principles. So you will see a large core a universal competency, and then you will see these principles filtered throughout at every different level of the competencies. And this is really driven by the evidence that we have so far. So what we know about human trafficking is that the majority of focus has been on women and girls, and it has been on sex trafficking. So it's really important that we are inclusive of all types of individuals, that we need to leverage the evidence base around trauma-informed and person-centered care, that survivors and those with lived experience have the most expertise in terms of what works and what doesn't, and they should be at the table equally and receive compensation for their valuable contributions in changing our systems. That it takes, that trafficking impacts people from a very diverse cultural and linguistic communities. And so we need to be adaptive to figure out how we can best respond to those. Certainly, as all of us know, and anything related to child-related anything, exploitation, that multidisciplinary is the only way that we can be impactful. But the other piece we really wanted to make sure is that we were leveraging what was the existing evidence base and setting up competencies that could drive further existence into what could become the new evidence base. So you will see kind of the core, which is our universal competency, which highlights very specific steps and standards related to trauma and survivor-informed and culturally responsive approaches. And then we take each competency through the system. So certainly understanding the nature and epidemiology, how do you evaluate and identify risk? Because part of the public health approach is not just responding to those who already experienced, but it is preventing those from becoming trafficked before, as well as caring for those who had a history long ago before there was a law or before they were ever recognized as having experienced human trafficking. How do you look at needs evaluation and what the individual concept and needs are about how to serve those patients and deliver patient-centered care? There's definitely some specific legal and ethical standards and concerns that are not unique to trafficking, but there are nuances to it that need to be understood and addressed. And then, as I mentioned, prevention, which frankly is the newest part of the human trafficking response. As Michelle mentioned, I've been doing this work for a while, and it's only really been in the last few years that we've been able to talk about prevention, not from a general awareness raising with posters informing the general public, but really looking at the science behind a preventative response that really digs in on how to change the results for individuals and families. So really important is that we also knew that there was a lot of different individuals, organizations, researchers, and educators. If we want to change the field and we want to change our systems, we have to look at each and every one of these. And so in every competency, we have broken out by individual practitioners, organizational responsibilities, researchers, and educators. What are the things that you should be aspiring to and ensuring that your staff and the students that you're teaching are all learning them. So you'll see that constructed throughout. And now what? So we are now in the process of pushing these out. I'm so grateful to Jessica and to NAPNAP for hosting us and trying to do this. We'll talk more later on about the different resources, but really the ask is disseminate, adopt, integrate these, test them out, challenge them, and transform so that we can really improve our patients' outcomes. So I will turn it over back to Jessica.
Thank you so much, Ashley. That's so exciting to see. As you said, this was it's a journey since 2017 that we've been working on. So it's so exciting to see the fruits of our labor. And next will be Hani. And I have to tell you that everything I learned about trafficking, I learned from NITAC and from HEAL. And in joining this, nursing was really late to the table along with other healthcare professions. But when I first met them, I did not know everything I needed to know. And they've just been so gracious and such an incredible resource. So if you're looking to really get more involved, you need to buckle in and listen to what HEAL Trafficking has to offer you, because there's such a tremendous resource. So Hani, I'll let you talk about HEAL.
And on that note, Jessica, just to reflect on how much I learned from my nursing colleagues each and every day, not only about how to better care for my patients in the emergency department, but also about how to better care for trafficked persons. One particular nurse comes to mind who had, there's this patient who had come in and out of our emergency department a ton. And one day she asked her the question of why, what was going on in her life, and just really met her where she was at and built that rapport and unfolded a story that involved both domestic violence and trafficking. And we were able to then really set her on a path to healing and plug her into so many services. But it was that key to unlock. She'd been in and out of our ICU, in and out of our emergency department, and no one had asked her those questions that really set her on a path of healing. And so I learn each and every day from my nursing colleagues. So I'm going to start off here by talking a little bit about HEAL Trafficking and our journey in this collaboration here. So our vision is really a world like what I just described, where every victim of trafficking who comes through the doors of healthcare are set on a path of healing, so that it's not an exception, but it is actually the rule. And when HEAL was founded in the fall of 2013, we were at a stage where we were learning so much about the intersection of health and trafficking. The studies had just come out that showed that the majority of trafficked people access healthcare there's my cat, while they're being exploited, and that represented this huge opportunity and responsibility for healthcare to respond to trafficking. And the way that I and my colleagues and co-founders at HEAL really tackled that problem was to figure out what is happening, what is the existing research that we know, how can we build through the power of the collective to be stronger together and tackle each of the issues at the nexus of healthcare and trafficking. And now we have folks within our network in 35 countries around the globe that are hungry for that information and those resources, and over 3,500 individuals, including those with lived experience, and a very multidisciplinary group. And everything that we do is from that public health lens, that we believe that we can't arrest or prosecute our way out of trafficking, that we need to look upstream. And I think healthcare is really critical in that public health response, because by intervening, even if it's identifying somebody's vulnerabilities and addressing social determinants of health, we can prevent them from being trafficked. Somebody that may have just become trafficked, if we intervene early, we're able to mitigate harm for those individuals. And then if we help them get out of that situation, we can also prevent them from being re-trafficked. All of that is critical in our role as a healthcare and public health players. So we are definitely stronger together, and it's been beautiful to really create this movement in collaboration with partners like NAPNAP and Office of Trafficking Persons and NITAC. So the story of core competencies definitely involved a lot of conversations along the way. But I would say that to me, it really comes down to this question: to heal or to harm? And to share just a couple of other stories, what we've been seeing as there's this sort of groundswell within healthcare and trafficking of interest, of good intention, of jumping in and sort of rolling sleeves up, is that sometimes in the midst of that good intention, with just a little bit of awareness, but not a lot of skills or knowledge, that harm can actually come to trafficked people that access healthcare. And that's, not by any malintention, but, early on when I was working on this issue, sexual assault nurse examiners told me the story of somebody that they had identified as being trafficked, and they didn't know what to do. They didn't have a plan in place. And so they reassured the individual and said, "Okay, honey, I'm going to call the police for you. I'm going to help you out." And unfortunately, what ended up happening is that patient who was trafficked bolted out of that emergency department right away. And what we know, the more that you know about trafficking, the more that we understand that those that have experienced trafficking have been forced to commit crimes as part of their exploitation. Their trafficker may be threatening deportation. All of their information is controlled by the trafficker. And there's a real fear, and rightfully so, of law enforcement involvement in a lot of cases. And so without having that plan in place, that opportunity was lost. And I unfortunately can share a number of similar examples from across the United States where that good intention can actually create harm. And so we at HEAL very much think about, how do we set the standards out within the field so that we're all on the right page and we're all with channeling that good intention in the right directions to ultimately improve the lives of trafficked folks who come through our doors. We recently did an analysis of a compendium of human trafficking 101, so basic trainings that were out there on healthcare and trafficking, and we're currently working on the final details of that report. But the themes that are coming out of that is that there's little focus on labor trafficking. And to me, that's so unfortunate, because we know internationally labor trafficking is more common than sex trafficking. And that's why I wrote labor, so that you you don't forget it. But the reality is that, like, as we're setting up what the landscape of the healthcare response to trafficking looks like right now, that is going to predict and set in place systems that will shape how we do this in the future. So it's not enough to say, oh, I'll do labor trafficking later, or I'll train on that later. Like, we absolutely need to make sure that we're incorporating this in the trainings and the systems that we're developing. And we've also noticed that there's a lack of survivor-informed trainings and not incorporating the voices of survivors, and a lot of sensational images that really do harm and propagate a lot of misinformation around trafficking, even within the healthcare space. So more to come, and excited to be able to share that final report. So just to echo what Ashley just had laid out for us in terms of the intent of these core competencies, there's this triangle, and I don't know how well it comes through on the other side, but it's from the medical education literature, and we adapted it for trafficking education for health professionals. But really that the idea is that, you know, it's not sufficient to check a box of, okay, I participated in this training, or I've given a training to an individual on trafficking. The awareness level is not the key. It's really that ultimate goal of improving human trafficking survivor health outcomes. And that involves not just awareness, but behavior change. And then, as we know in the medical realm, competence. So some services that we can offer, I put the HEAL website link here again, and it's really a range of things in terms of really kind of that customized training. Folks have been coming to us to say, we're designing this training for health professionals. How do we make this individualized for our specific town and what the trafficking trends are locally? We do train the trainers. We have a speakers bureau that are able to provide higher level trainings than beyond the 101, though certainly we can do those 101 level trainings. Protocol technical assistance. So to really, I think about this kind of like, you know, you might have a great car manual, and HEAL created a protocol toolkit for health systems. And these core competencies are fantastic, and they really benchmark where we should be going. But, you know, you're not going to get behind the wheel of a car with just reading the car manual, right? You need someone to come alongside and really help you in that process. We're happy to do that. And we have a number of tools. Many of these are created in collaboration with others. I mentioned the protocol toolkit that was a collaboration with Hope for Justice. We have a tool that can be used to assess your curriculum to see whether it really is up to snuff in terms of the variety of boxes of both design as well as content. And then, of course, what we're talking about today, the core competencies. And you know, everything that we do actually echo very much as Ashley was sharing the core principles for how we were approaching these core competencies. So many of these really resonate with how we think about everything that we do within HEAL, that we engage in all forms of trafficking, that it's really important for us to not only incorporate the voices of lived experience, but have those voices at the table in every stage of the work that we do. And of course, are trauma-informed, evidence-based, and practice-based. So to learn more about what we have to offer, you can check out our website or email us here. And really excited for the discussion that will follow. So I'm going to stop sharing now.
All right. Well, thank you so much, Hani. I'm going to pull up my PowerPoint now. And those are all such great resources. So if you didn't hear anything else, get on the HEAL Trafficking listserv, because that is a great resource, and it will tell you, keep you informed of new research that comes out, or especially their trainings. They have a lot of really great webinars. You can go onto their website and look at the webinars. And I know I follow those, very closely, and it's good. So my job is this evening is to bring it down specifically to nursing, and to talk about specifically how nursing can engage as a healthcare profession in this. And of course, we were invited to participate in the core competencies, which I'm so grateful that we were able to represent nursing in that way. So I want to kind of talk about, updates in healthcare. We know that originally we saw studies that showed that 84 to 87% of victims consistently accessed healthcare while being trafficked. And, there's some range in numbers of that, but basically the bottom line is victims are still encountering healthcare professionals and coming into healthcare environments for care, and our awareness still remains low. For me, I've been in academic nursing for 15 years, and so I'll learn about something new, and I may go and do a lecture for a year, and then it's like, okay, everybody's sick of hearing about that. But I've been talking about trafficking for almost 4 years now, and my husband said, well, how long are you going to talk about this? I said, till I go places and people still are not shocked, till I go and there's no line, waiting to talk to me and ask me questions. So I still see that awareness is low. Less than than a third of scholarly articles on human trafficking are published in health journals. So this is really concerning. And as both Ashley and Hani have said, there's a continued lack of recognition and inclusion of labor trafficking in healthcare. We're focusing on sex trafficking, but not healthcare. And an organizational, there was an article that came out looking at medical organizations that showed, this was as of last year, only 8 of 265 medical organizations had any resources available for their members to engage in an effective response to human trafficking. And this is just about to come out for publication, but in our review of 110 nursing organizations, only 10 had a white paper or a policy statement or anything, even raising awareness. And I feel like that's something that we can use as nursing organizations, because we have a powerful voice to our members in keeping them aware and update of, hey, this is something that you need to know about. This is an emerging health threat that you need to learn about. Because after, we graduate from school, I think about things like genomics. If you graduated before the human genome was mapped, which is some of us on this call, you're not going to have gotten that in your curriculum. So it's really important. And evidence-based education is essential. And as you saw in the core competencies, it needs to be trauma-informed, survivor-informed, victim-centered, and culturally responsive. So we started at this as NAPNAP. We go by a short name too, like NITAC, at the National Association of Pediatric Nurse Practitioners. We started with a member survey just to see where are our members on this. And we had 99% said, yeah, I believe that this is a pediatric health issue. It should be framed as a health issue. 91% thought that sex trafficking or commercial sexual exploitation of children was a problem, but only 78% thought labor trafficking was a problem. Only 30% could differentiate between sex trafficking and labor trafficking. And while 87% felt like maybe I could encounter a victim in my practice, only 33% felt knowledgeable about what to do, and only 24% felt competent to identify a potential victim. So this was kind of the catalyst for us as an organization, seeing this real knowledge practice gap that, we know that you're thinking it could happen, but you don't know what to do. And that's just not a comfortable place to be as a healthcare provider. So in 2016, we actually started NAPNAP Partners for Vulnerable Youth. And in 2017, we established the Alliance for Children in Trafficking, where we really, made it our mission to engage nursing as a profession, as experts in pediatrics and advocates for children, and to really engage in advocacy efforts and education experts. And we've also had the ACT Advocates program. So you can go to our website, napnappartners.org. You can find all of those resources. The HEAL resources are on there. SOAR resources are on there. Resources that you would need as a healthcare professional are all right there. And we started our ACT Advocates program, which is our Train the Trainer program. And I'll give you some statistics on that in just a minute. So we started with writing a white paper. It was actually NAPNAP's first white paper as an organization. So that was really exciting, and really issuing this as a call to action, saying we need to recognize this through a public health paradigm. That was really our call to action, talking about, how do these victims present in a clinical setting, and what are calls to action, because we had no evidence to base our interventions on. When I did the first literature review to look, trying to get evidence-based clinical interventions is very difficult. The other thing I've been doing is looking across other nursing settings. I've been working with APSNA, the American Pediatric Surgical Nursing Association. They asked me to write something for them. I looked in the pediatric surgical literature. I found nothing. But in looking at the reports, looking at criminal reports of presentations and victim experiences, I found many, many case reports of surgical presentations. Patients presenting with physical trauma or organ trafficking or burn victims, which of course organ trafficking, transplant tourism is a whole different other controversial topic in and of itself. So if you're an expert out there, I know that, and you can read more, but they came with reproductive injuries or disorders or genitourinary presentations. We're seeing an uptick in requests for plastic, reconstructive, aesthetic, or cosmetic procedure requests. And then also just trying to think about, looking at responsibility for supply labor chains, looking at where do you source your surgical instruments and your gloves from and things like that. So all we can do basically at this point is a call to action action and say, okay, there is no scholarship here. There is no formal engagement. We need you to get engaged. We need you to know. So we've also been talking about family nurse practitioners, because you think that victims only present in the emergency department. And while a large portion of victims do present in the emergency department, they present in many, many clinical settings. And so we have to be ready for that. And I liken this to, like Connie said, if you're trying to figure this out after a victim presents to your organization, then you're at risk. Your safety is compromised. The safety of the people in your organization are compromised. It's like trying to figure out what your response is going to be to an active shooter. If they come in, when you have this intersection of criminality, there is a potential for unsafe. And I'll give you an example from my clinical practice. I work in a pediatric primary care. There's really nothing special about my practice. It's just a little, mom and pop style kind of small office where there's one provider, and he works at the emergency room a few times a month, and I fill in for him. So I was there by myself. I had this 4-year-old girl that presented, and after assessing her and assessing the situation, realized that she was being trafficked by her father. And I'm thinking there in that moment, like, okay, it's just me. I'm the only provider in the clinic. I've got a nurse. I've got some front office staff. I have a waiting room full of patients. And I'm thinking, is this dad going to show up? Like, what's going to happen? What am I going to do? And recognizing that you have to be ready. I've been working with the School Nurses Association to engage school nurses in efforts for this. And this was interesting in doing an integrative review of the literature. Again, school nurses, just like all other nurses and healthcare professionals across the board, have misperceptions of stranger danger and abduction, especially for children. This can be a harmful narrative because we think that the way that we need to protect children from trafficking is by warning them about the creepy guy in the white van at the grocery store parking lot. But that's not how this happens. And so if we don't recognize how victims are groomed into trafficking and how the complex trauma bond occurs, then as nurses, it's going to limit our ability to impact and be able to respond effectively. I give this an analogy a lot. It's like when you go to the optometrist, when we walk into a clinical situation, we have lenses that are coming in front of our eyes right and left. We're looking at it and we're thinking, okay, is it clear 1 or clear 2? Is this substance use disorder, or is this, suicidality? But we don't have a lens for trafficking. And that's what we see here. So we see that underrepresentation of nursing, we found 10 resources that were identified nationally for use in school settings. 7 were from the federal and state government, 1 from an academic medical center, 2 from nonprofit organizations, but only 2 addressed the role of the nurse, and none of them involved nurses in their planning, which is, just a significant, we're just not at the table there. So there's a lack of collaboration with school nurses. And we found that nurses with higher education were more likely to implement evidence-based programs. And so how can we partner with schools to implement this? As Hani said, and Ashley said too, the importance of professional trainings is so important. I experienced this when I first started becoming aware of trafficking, and well-intentioned but ill-informed professional trainings. It was also difficult for me to go into some care settings to give trainings because they had already had a presentation from law enforcement, which again, as Ashley said, is a very critical piece of this puzzle. But without the translational piece, without what does this mean to me and how do we work together, healthcare was having a hard time connecting. They were saying, how do we connect to this? And we're seeing, of course, in COVID-19, a rise of disinformation. And that is very difficult, and kind of a false narrative that's surrounding a harmful narrative about rescuing children. Even if you see headlines across the country that say, 34 children rescued in this human trafficking operation, if you go down and you read the article, you'll see that the majority of those children came from foster care settings or juvenile justice settings. And many of them likely did not even recognize themselves as victims and may re-enter their trafficking situation. So we've got to have good education that addresses common myths and misperception, implicit bias. We are susceptible to trafficker deception. We think we have a cultural stereotype of what a trafficker might look like, but traffickers can be pastors or teachers or coaches or mothers or all kinds of people. And we have labeling of presentations. Again, well-intentioned, but looking at things like teenagers choosing prostitution. Well, children cannot consent to commercial sex, or looking at drug addiction through a singular lens, or homelessness. All of these are not necessarily indicative of trafficking in and of themselves, but the more compounding risk is concerning. And I don't know about you, but again, I'm seeing just so much on social media stories that they almost always start like this. I don't usually post things like this, but I was almost abducted by a trafficker in my grocery store, tonight. And then everybody gets on there like, oh, human trafficking is terrible. Oh, those, horrible people trying to kidnap those sweet babies, right out of the cart. And that's just not how it happens. And so we need to be educated and prepared to do that. As you heard before, and NAPNAP Partners was instrumental in helping to pass House Bill 2059 in Texas. This is my daughter here. She came with me when I testified on behalf of the bill. So very proud to involve her as a future anti-trafficking advocate. But the way that this started, I want to tell you the story really quickly in case that those of you who are in other states want to replicate this, because mandated CE is a very controversial topic. It's not very popular. And we've had a lot of conversations with the Education Committee and Heal Trafficking, because it can be everybody's pet project. Like, I want you to mandate you learn about, pinky toe infections. And that's difficult. But in Texas, what happened was there was a legislator who was determined to pass this legislation, and he was going to do it whether he was helped or not. And so all politics is local. It happened to be the cousin of the president of Texas Nurse Practitioners, who I had served with at AANP as the state rep. And she said, oh, I know somebody. So I helped advise on that. And he partnered with a Republican. He was a Democratic representative out of El Paso. He partnered with a Republican representative out of Houston. They came together to do it. Well, some interesting things happened in the legislature, and it really it helped to reframe this as a public health narrative. Because when I went in to testify, I looked at Texas law, and they had mandated training on the books for truck drivers, for police officers, for transportation workers, and several other commercial industries, but not healthcare. And so I think that was just representative of healthcare not being at the table. So I was very determined that if we were going to do this, we would do this right, because in other states, there is a lot of commercial predatory activity where CEs will come in, especially the millions of healthcare providers in Texas. I knew that they would be swarming to try to make money off of this mandated training. So as luck would have it, Emergency Nurses Association was in Austin, and Governor Abbott sent his staff to come and listen to our presentation at ENA. And I was able to connect them with Hani, who graciously gave them HEAL and excitedly gave them HEAL guidelines. And that's what they use. And so every training is developed according to the HEAL guidelines, and it is approved by the Department of Health and Human Services. And so that's really important as a model going forward, that we have some standards, that we are giving good training, because again, like Hani said, if we're giving poor training that's well-intentioned but ill-informed, it can be harmful to victims. So looking at NAPNAP Partners, this is actually, these data are just kind of exploding. This was at the end of 2020, but we can do more than we think we can with less than we think we need. We have had actually over 1,000 people now take our 3-part training, which is available on our website, kind of a deeper dive specifically for nurses and for pediatricians, for pediatric nurses and pediatricians, that is on there. And we have 35 ACT advocates, which actually we have more than 50 now in several states, and we have trained several thousand healthcare providers across the country. I would be remiss for me to say, not to say something about COVID-19. Of course, in this time of increased vulnerability, the attention of the healthcare profession is just hyper focused on COVID-19, but exploitation is ongoing, and it's difficult because attention is diverted, and all the momentum we had is going down. And I do have to give a shout out to Dr. Jordan Greenbaum from Children's Healthcare of Atlanta, and she is the medical director for the International Center for Missing and Exploited Children, with emphasis on exploited. A lot of times you just think missing and the milk carton, but it's also exploited children. They reported a 4-fold increase of reports in exploitation and abuse, and we're talking millions of reports, and 70% of those came from social media messaging systems. So that's really difficult. So things that you can do, please, please, please work to implement the core competencies. This has been, like you said, almost a 4-year project in the making. These are all of the tools and the nuts and bolts that you need as an individual clinician, as a healthcare organization, as an academic institution, and to do what you need to do to be able to start to be competent on your care for trafficking. You can take our ACT Advocate training. You can sign up for the HEAL listserv. The ACT Advocate training does incorporate several webinars from HEAL and the SOAR training that is available. So that is free training that is available, and I would encourage you to look at that. And especially for nursing, if you have doctor of nursing practice students who want to do a project on trafficking, again, I'm seeing a lot of those well-intentioned but ill-informed. Our ACT Advocate training is a perfect launching platform to be able to give them some expertise of what they need for responsible representation of victims. So connect them to that, and you can also connect your faculty to that. And when you've completed our training, you will be able to do a basic training in your class for that. So those are the things. And lastly, I'd just like to invite you, if you haven't already, to listen to our podcast. We did have an episode with Teresa Zielinski, who is the current chair of the Alliance for Children and Trafficking, and Dr. Jordan Greenbaum did an episode from the International Center for Missing and Exploited Children. So those episodes are there for you to listen to if you want to hear more details about their work. So we're going to move to questions, and I'm going to stop share so you can see us a little bit better. I'm going to start, if you have questions, go ahead and start putting them in the Q&A box. Michelle is going to help me watch those and let me know if I miss any. But I'm going to start with some of the questions that were submitted beforehand. And Ashley, I'm going to give this question to you. There was somebody that was really interested in the culturally responsive elements of training, particularly for Native Americans and Alaskan Natives. And I know you have a lot to say about class and about culturally responsive training. So I'm going to give that one to you.
Yeah, so I can do both resource, but also then when you consider development of those resources. So again, similar to any outreach or training that we're doing, we want to bring the people that are lived in that reality to the table and bring them in the development of that. So for example, we have quite a bit of different activities and resources we developed through NITAC that look specifically at Indigenous and Native communities, as well as other different sectors and categories of culturally vulnerable populations. So you can find, if you go to our website, we've got a SOAR for Native or for Indigenous communities. It's actually just being relaunched with branding that changed it to Indigenous based on feedback we received from our partners, consultants, and fellows that went through our Leadership Academy. And that is one of a host of, I think we're now at 11 different SOAR online modules, the majority of which are all accredited training modules. You can get them if you all are using the system Train, which is one of the largest public health platforms for learning management, or if you use HealthStream, which is in 70% of the hospitals, you already have access to it, and you can reach out to us and we can talk to you about how to pull that in. But I think that is one of the things we learned when you look specifically at cultural competency and cultural humility, that learning from those that have walked that walk is the most critical piece of it. We have a separate part of NITAC that's called the Human Trafficking Leadership Academy. We just finished an entire 6-month fellowship program for Indigenous and Native community members. I encourage you to look at those recommendations. We're actually in the midst of recruiting for our latest Human Trafficking Leadership Academy, and this one will be looking at communities of color and systemic and race and inequities and racism. So lots of really interesting ways to leverage those different kinds of nuances. But the biggest piece I would say is make sure you've got the people that you're trying to reach at the table and with equal access and engagement.
Thank you so much for that, Ashley. And yes, absolutely. And you can also find the link to the SOAR training on our NAPNAP partners page. So if you're looking for it and you can't find it, we have it linked for you, because there's so many individualized training, and there's training on trauma-informed care. There's a lot of great training, so don't miss that. Hani, I'm going to give this next question to you because you talked about this a little bit in your presentation. For nurses who want to get involved on the local level and start in their communities, what are steps that they can take to be effective and responsible advocates?
That's a great question. They should start by doing your ACT training. um, I would definitely plug that. And I just wanted to reflect on one of the things that Ashley said, which was we were trying, before SOAR was integrated so well into HealthStream, we had tried to integrate it into my own health system. And then we recently went back and they're like, yeah, they're all there. And I'm like, this is so easy. This is so amazing. So just really having it be integrated at that ubiquitous level, whether it's through that public health system that I'm not less familiar with, or your health stream, that many of you will be able to access that. You just have to know how to search for it. So just to answer that, I think whenever you're starting out, I think the first step it really is to inform yourself, which is why I was sort of facetiously saying to go to a credible source to inform yourself about the issue before you even start engaging with community partners that are doing the work, because that will just really pave the way. So many of us that work in the field have to do that basic level of explaining, and you just don't need to start from that place. Start from an educated and informed place from a credible source, and we've certainly flagged those. Then I would say the way that I approach engagement and what I did in my own health system when I was first working on this was coming with that humility and mapping out what was already being done in my community, because I knew that all of those local experts, whether they were legal aid, whether they were law enforcement, whether they were those with lived experience, they've been doing this. They've been in the trenches for so much longer. And I come and bring that healthcare piece and that healthcare intersection, but just to come with that attitude of humility, and then be ready to do that work of sort of mapping out what those resources are. It's all very decentralized. I wish I could say, okay, there's one particular place that you can find all of the anti-trafficking folks there. But what I'll do instead is to kind of give you a sense of where you might look. So there, in many locations, there is a task force for human trafficking. They can be variably funded. They can be variably aware that healthcare, there's even an intersection with healthcare, or aware of public health, but they can be and often are a resource in your community, but with those caveats. If you're noticing in the spaces of anti-trafficking that there is not much mention of labor trafficking, that is actually a common thing that we see in anti-trafficking response across the country. So you might actually be bringing that level of awareness to folks. And what I would encourage you there is, if you don't see like Department of Labor or migrant advocates at the table in the Anti-Trafficking Coalition, you may be that bridge that's bringing them in, but you absolutely, to understand what are the trends in labor exploitation and labor trafficking, you need to reach out to those folks. And they might be working with asylees, they might be working with migrant health, but make sure you're not leaving out that labor trafficking piece, and you might need to do a little bit of extra work to make that happen. The National Human Trafficking Hotline also has a compendium of resources that's variably updated in a given area. And so you should be able to put in at least your state, and sometimes to some level your city, to get a sense of what resources that they refer out to. And I don't know if Ashley, you would add anything to that, but that would be sort of some of the basic first steps. We lay all of this out in the HEAL Protocol Toolkit, where we have kind of almost a checklist to think of this group and this group and this group, but that's really where it starts.
Yeah, I'm just going to put in a few other spots. When you look at federal funding, there are a couple of different federal agencies that put out a lot of grant funding. So you can find actually dedicated trafficking programming in many places. The person that funds our program, the Office on Trafficking in Persons, has a national program, which means that anywhere you are based in the United States, if you are working with a migrant survivor of trafficking, you can receive access through a per capita funding program to support them. So there's a lot of different other resources out there as well. And I would again leverage both the HEAL listserv, NAPNAP's resources, and we also have a listserv that you can stay informed on different things, but I'll post a few other things on the site as well.
Thanks, Ashley. Yeah, and to recognize that some areas don't get, they might be funded this year, but they weren't last year. And so that's variable too, but I think it is a really good place to start. And then just to speak from my own personal experience, my strongest champions and collaborators, and even to this day, and now my friends within my health system, are those that have been working on sexual assault, domestic violence, child abuse for years. And we end up often using similar pathways for referral. They're definitely my collaborators in thinking, how can we make this more victim-centered? How can we make this more trauma-informed? How do we change the way the operations happen in the hospital? Because they've been at the table with leadership for so long and have all of that institutional knowledge. So those are just some overall tips and ways that I approach it, as well as how HEAL thinks about it, and a bunch of resources that we threw at you. So hopefully you're taking notes.
I think those are all great answers. And from my own personal experience, it is all about the community coalition building, because you can't just, address this in a silo, even from healthcare. I mean, we can't be a healthcare savior and rescue them and take care of all of their needs. We need aftercare. We need social workers. We need community advocates. We need lawyers. We need police officers. And I've seen that, it really depends on even county. I live in a tri-county area, and, each county you're going to have a very different outcome just based on the coalition. One county has a very well integrated coalition that meets regularly. It includes all of the local elected officials, as well as the state level elected officials and the federal elected officials that all come, as well as the CEOs of the health systems in that area, the police officers, and even calling your local police officers and finding, like, what do you do? How do you respond to this? Do you have a trafficking resource officer? What's going to happen, if I call? Because as Hani alluded to earlier, we don't want to call it, and you have to know the law in your state, because if certain actions that you're compelled to do while trafficked, if you're compelled to do criminal actions like traffic drugs or something like that, and you can be prosecuted for that, and you call the police, well, that can be a very negative outcome if you're trying to figure out, again, if you're trying to figure it out on the fly. That's just never going to be a good outcome. So I think even as nurses, we can initiate that and start to lead that. Or another thing that I found is a lot of those coalitions do not have any nursing representation. So we have an important voice. So calling them and saying, I noticed you don't have any healthcare representation or any nursing representation. I would really like to, sit in and to contribute. I've had a lot of colleagues that have gotten in that way. So I think, there's the possibilities are really endless. And so again, if you're following NITAC, HEAL, NAPNAP partners, we're going to continually give you resources in that way. The next question that we have coming up, I'm going to take a first crack at this, because it's how our faculty persuading their institutions to incorporate human trafficking into the curriculum. So this is a tough one. And Hani and I have had discussions before, and something we probably need to pick back up is going to the Joint Commission and talking about, creating standards concerning care for these individuals. But it is difficult because it's not in curricular standards yet. That is something we're working on with AACN as far as from a nursing perspective. But that's where I feel like professional nursing organizations can play a very important role. So we give you a platform to stand on. So when you're going to your curriculum committee and wanting to integrate things in there, you can bring the white paper, you can bring the position paper, you can bring the federal government, the NITAC's report saying these are the core competencies for academic institutions that have been issued. These are very, high level standards, even looking at HEAL Trafficking's curriculum standards that have now been adopted by the state of Texas. So these are being adopted and credible on widespread scales. And so I would do your homework and get all of those resources and take those in with you. So Hani and Ashley, do you have any advice on that question?
This is why we created the core competencies in part too. So we look to all of you to really transform these into action. And so your professional societies best, or know someone who knows them best to really turn the tide and get take these core competencies and get them to be the foundation and be the standards for all of our trainees. We welcome partnering with all of you. If it's helpful for us to join you in your data sharing, what have you, like this is highest priority for us. And I think this is really what creates the movement and creates the change that we want to see. So just by asking the question, I know that you're already thinking about this, but thinking about what are the accreditation bodies and how do we make inroads with those we need to go to each and every body. So
Ashley, anything to add?
Ditto. I do think, really we're here to be a partner. So I think one of that is it takes the village and we're all part of it. So if we can partner up, if you have feedback for us on how we can adapt to create different versions of things, right? So like you'll see if you go to the competency page right now, there's 3 versions. We're actually looking at creating a self-assessment tool that looks at from an organizational lens, from an academic lens, and from a individual clinical lens, so that you can get a baseline for yourself on how to do that. So if there's other ways that we can be creative that will be receptive to the folks that we're working to adopt these, just let us know. We'd love the feedback and are all about give us the answer.
And I'll give Hani another shout out because she's actually written several articles and some collaborating with a nurse expert in human trafficking about curricular standards. And I think it's a 3-part series, right, Hani, that you wrote?
Yeah, collaborator, Kathy Miller, and we went to different stakeholders within healthcare to really see what do you think are the elements that should be there. And that very much informed this core competency work, including those with lived experience. There's an entire article that specifically gets at what do those with lived experience think should be the things that all health professionals know about. And that, honestly, her, Dr. Kathy Miller's research really opened my eyes to how much judgment trafficked survivors feel when they access healthcare. And I was just aghast because, that would never be my intent to make somebody feel judged, but it's all the things that they might hear in the environment being said about them, and then also coming from a place of fear and shame based on their trafficking experience. So I would definitely check out those articles that were co-authored with a nursing collaborator.
Thank you so much. All right, we have just a couple more minutes. Does anyone else have any other questions that they want to ask? You can type it in the chat, or I think Michelle can make the magic happen and you can ask us. Michelle, do you see any other questions or anybody raising their hand or trying to get our attention?
I do not see any hands raised, nor do I see any questions in other areas.
All right. Well, we are coming to the end of our hour here. And I see, Geraldine, that you put in the chat about, working with adult survivors of sex trafficking who have children. Absolutely. I think, and Ashley already answered you about how important it is that the family approaches, which is great because especially as pediatric advanced practice nurses, that is definitely in our wheelhouse and we can definitely do that. And I would just end with echoing what both Ashley and Hani have told you, is that the prevention work is really in its infancy. Even though we want an upstream approach, I feel like as nurses, we're very well positioned to do that because prevention is so ingrained into our nursing model and the way that we practice and our emphasis on wellness and prevention. And so if you're wanting to, get involved and get jumped in that, then contact us at info. You can do info@napnappartners.org. We would love to hear your ideas for scholarship or to collaborate with the Alliance for Children in Trafficking to start to create, as has been said before, scientific ways to measure prevention and to really be organized in our approach rather than just raising awareness. I feel like we're starting to reach a critical mass there where more people are recognizing this is an issue and this is a problem. And we have a unique position, especially as pediatric nurses, to really speak into the lives of these vulnerable children to be able to prevent these lifelong traumas that we've been talking about. Ashley or Hani, do you have any last words you'd like to say?
Thank you so much for this opportunity to share with nurses. And as I said in my opening remarks, I've learned so much from my nursing colleagues, and I think these collaborations are really, really key. It does take a village, and I really look forward to see what comes out of this conversation tonight. And we really need all of your help to move the needle forward. So thank you so much for creating this space, Jessica.
Yeah. And again, I'm always following Hani going, ditto, yes. So no, thank you so much. I'm also incredibly excited to see the momentum that will come out of this and how we can be continue to expand our partnerships. It really does. I have spent a lot of time working on the criminal justice side of it, and it's only in creating NITAC that I got to move into the public health approach and feel like there may actually be in the long term a solution towards ending this instead of just reacting to it. So really grateful for the wisdom and expertise that each of you bring and how we can partner together moving that forward.
Well, thank you so much to both Ashley and Hani for joining us. You both are incredibly busy doing incredibly important work. And I've seen both of you in Congress and on television. And the fact that you joined us here tonight is really just such a testament of your passion for the work for this and your belief that really we as healthcare professionals, and specifically tonight on this call, nursing, as I said, I see a lot of nursing organizational leaders and very high-powered go-getters out there. So I look forward to seeing what could happen. We want to continue to increase dissemination of the core competencies and increase awareness that they are here. So if there's any way that we can partner with you in that and disseminating this information to your healthcare organization, to your professional nursing organization, to your academic institution, please reach out. We'd be happy to do that and to give you some resources to be able to do that, to integrate that. Ideally, everybody on this call would have a task force in their organization to implement the core competencies as applicable and create outcomes measurement systems. So we have high hopes, but it seems like every time we set the bar high, everybody meets it. So, and Ashley and Hani, I have our illustrious radio host on here. She hosts the Nurse Practitioner Show on Dr. Radio on Sirius XM. She is so gracious to host us the first Thursday of every month, but she has other shows, and she's saying she would love to have you on her radio show. So while we're recording, and I have you on the spot, I'm going to get a binding contract in the state of Texas.
Sure, absolutely.
All right, Pat, we'll put you in touch. Pat is the best radio host, so we'll put you in touch with them for Sirius XM Dr. Radio and be able to talk about this, because that would be really a fantastic point of dissemination to be able to do that. So we'll be in touch. All right. Well, thank you everybody for joining us tonight. We really appreciate it so much. This video will be posted and recorded and posted. So if you know somebody that needs to see it, if you have a student or another faculty member or anybody that needs to see it, you are welcome to share the video and have them reach out to us with any questions. Thank you for everything that you do as experts in pediatrics and advocates for children, and have a great night.